All right. Well, welcome everybody to our From the Clinic to the Living Room. We're in my living room. Thanks for joining on this special night. Thanks to a band concert we had to reschedule. So Dr. Glitza, I am so thankful that you let me be a mom last night and handle all of that. So my special guest tonight, all of you listeners, is Dr. Isabella Glitza from MD Anderson. This is a very much anticipated webinar. I will tell you, we have a very high attendance tonight because the topic of brain metastases is not well discussed. I can tell you that from practicing in clinic, there are so many folks that have millions and millions of questions about prognosis and where things go. And so I think there are a lot of very eager listeners. We're going to try to handle as many live questions as we can within reason, just because with HIPAA, I try to avoid, dealing with specific questions in a live setting. So we'll try to generalize them as much as possible. But yeah, without further ado, thanks for joining me. My biggest thing is we want to start out with I have a diagnosis of brain metastases. What do I do? Where do I go from here? So if you want to just start there, I think that would be the most helpful, what do I do? Now what?
Absolutely. And first of all, thank you very much for having me. I'm super excited. I hope I dog and cat proofed and husband proofed my door to my office. So hopefully we'll keep the interruptions at a minimum. And sorry for a few seconds of computer issues. So I think when I think about brain mets and melanoma, and obviously this is specifically geared to patients with melanoma brain metastases, I think my first piece of information to you as a patient would be you're not alone. As a matter of fact, we do know that a very high number of patients with metastatic melanoma will develop brain metastases during what we call, the course of their disease. And the numbers fluctuate a little bit when you look into the literature, but there is probably that about up to 20% of patients, when they are being diagnosed with stage 4, have already brain mets in place. And we know that up to 70% of patients with, again, we're talking about a metastatic melanoma patient setting, not about stage 1 or stage 2, will develop brain mets. And I think it's important to know, because I think it takes a little bit the initial, oh my God, am I alone? Is there anybody else who's like me out there? And the answer is yes. And I think it's very peculiar because melanoma, as everybody on the call is, very well aware, is such a weird beast, right? We measure it initially on the skin in millimeters, which is really the only tumor that we talk about, 0.6 millimeter. But it has, of all the when we call solid tumors, that means all the tumors kind of arising from organs like lung, breast, kidney, bladder, liver. So melanoma, of all these tumors that derive or arise from organs, actually has the highest likelihood to travel to the brain as well. So again, my first answer would be you're not alone. And then I would start looking at the scans and go from there.
So in your experience, is it more common to have a solitary brain metastasis or multiple brain metastases at once? I know we get that question a bit.
Yeah, so it is actually all over. It's all over the place. So, and I think kind of weaving into that question is also this, how do patients present? Meaning, how do patients even figure out they have a brain met? And so what I would say that, a single or solitary brain met, we do see often, I mean, not uncommonly, but I think more often is that we see more than one. And then depending on how many we see, it's called oligometastatic, meaning there are multiple, but not again many. And then there are patients that come to my clinic that have 20, 40, 50 brain metastases. And I think along kind of the same lines, patients present very different. And again, when we say present, it kind of sounds like a little bit cold, but when they kind of come and seek medical help, some patients, just have been feeling bad, they've had a headache, they've been nauseous, and then they develop stroke-like symptoms and they end up in an ER. And somebody then does a CAT scan because they think they have a stroke, and sure enough, they are found to have a mass, and then, you know, they undergo resection or other things. And this is sometimes the first time that patients are ever diagnosed with melanoma. And so that can happen. But then, of course, patients can just have metastases as we look for them. So we do actively look for brain metastases in patients that are stage 3, and I know we talk a little bit later. We should maybe at least mention a little bit later how often should we screen or not, because the guidelines are not great. And for stage 4 patients, we obviously look even more actively for, because we know based on the number that over 50% of patients will develop potentially brain metastases.
Right. So do you want to talk about that now, or do you want to talk about surveillance at the end, do you think?
Well, I think maybe we should even use it right now, because I think the follow-up after we successfully treated brain mets is a little bit different than who should have brain MRIs. And the one big disclaimer I would have to have is that insurance sometimes can be an issue. So my preference, and this is not necessarily, and I would like to, you know, point out what is guideline and what is maybe my own preference. But if I do have a patient with active disease in the body that is on treatment, my preference is to scan the brain every 3 to 4 months. Obviously, if symptoms develop, I would obviously scan them much earlier. But that is my preferred scenario. It sometimes ends up being every 5 or 6 months. This is okay as well. But I think in stage 4, especially with active disease, a somewhat regular, what we would call surveillance scan, is actually really, I think, warranted. And I would say that most patients in the US will get that. For stage 3, it becomes very, very, very tricky, because
it's very gray.
You know, stage 3, it's not only very gray, but if we think about, and again, the goal of today is not to talk about stage 3 patients, but again, everybody on here is somewhat familiar with melanoma. Stage 3 has so many different subcategories. Again, you know, stage 3A through stage 3D, and they are very, very different beasts. And their risk of relapse is very, very different from a stage 3A compared to stage 3D. And so if I can, I would probably screen the higher stage 3s a little bit more often again, if I can get away with it. It's not an absolute must to do it every time, but obviously whenever I have somebody who becomes a stage 4 from a stage 3 or stage 2 or stage 1, a brain MRI at baseline is absolutely mandatory. I think that is in my mind a must.
Right. So that's what, whenever I was prepping for this, I was looking like, are there guidelines? Are there actual guidelines? Because I know what we do in our practice might be very different for what someone in the community might do. And there really aren't. Like it says, you know, look for metastatic disease in stage 3 and stage 4, but it doesn't really say like every 6 months or every 3 months you should do this. So I think and please correct me if I'm wrong, but like a generalization is like, you're not doing this for stage 1 and stage 2 unless they're symptomatic. And even in some stage 3 patients, you know, this surveillance might be long. And then, you know, until they have symptoms or develop metastases, you're not really going to do this routinely like you would for a stage 4 patient.
Correct. Absolutely. So stage 1 and stage 2, as you know, there's also the great debate about, you know, a stage 2A, again, very different, often disease course compared to stage 2C patients. So I would say stage 4, absolutely, at least at time of diagnosis, and then at intervals, if I can get them, and of course, at symptoms. And that's, as you said, the NCCN guidelines always say as indicated or as clinically indicated. And again, as I just mentioned, sometimes we catch, or actually in a good number of patients, we catch them and they are completely asymptomatic. Our patients, they don't know they have brain mets, and we find 20. And so I think regular scans for stage 4 are warranted and should be at least submitted to insurance. I think that's a good way to put it. And then in stage 3, as you said, especially the higher, I think would require more frequent monitoring. And again, though, what happens though later on after you hit kind of this nebulous 5-year mark, you know, the jury's always out there too. Do you continue with CAT scans? Do you continue with MRIs? And I think these are discussions that we do have to have with our patients that are very individualized. Depends on their response in general. Are there any disease sites left and things like this? So
Sure.
I know we spend a little bit time on this, but
it's important. People want to know.
It's important to know. Yeah, I think it is important.
So now you have a diagnosis of a brain met for whatever modality or whatever. What do we do? Like, what is the treatment? How are these patients being addressed?
And yeah, so that's when I kind of jokingly said, and then I look at the MRI. I hear brain mets, and then I look at the MRI, because the first two things that go straight to my head, and I'm a medical oncologist, so I'm really not the one who delivers radiation or cuts things out. I'm the one with the drugs, as I jokingly say. And so what I need to know is how many, as you kind of said. Is it one? Is it multiple? I do need to know the location, because some locations in the brain are a little bit more difficult or worrisome than others. If a brain metastasis is sitting right at a spot that could, you know, cause issues, including death, I need to know, right? And I need to keep this in mind for my decision making. I also need to know, is the patient symptomatic or not? Because if a patient is symptomatic or not, we need to discuss, does this patient, a surgery becomes maybe a little bit in the forefront of my head. And I said, is this a patient who would benefit from a surgical resection up front? Do we need to start the patients on corticosteroids? And maybe I should just say this now in the very beginning. When I talk about steroids, you know, very broadly, I typically refer to this as dexamethasone. That is the preferred steroid that we use for brain swelling. And that's a little bit different than the prednisone that we use, for example, for toxicities. And I'm sure that AIM had another, you know, great series on toxicity management in the past. So we prefer dexamethasone because of its slightly different brain penetrance. But so I'm looking at all this, and then I'm also thinking about, does this patient has a BRAF mutation? So I'm already gauging what are my, again, drug tools that I have. But I think the most important thing that I'm doing in my head is I'm running a miniature multidisciplinary conference. And I think it's actually really, it's kind of true. And what I mean by this, I'm trying to already guess what my colleagues, the neurosurgeons, and what my colleagues, the radiation oncologists, will recommend with their little hat on. And so I think actually it's very, very important. And I think more and more places in the US and worldwide are really treating patients with brain metastases in what we call a multidisciplinary fashion, where the patient is not only just treated by the radiation doctor or the surgeon or the medical oncologist, everybody is at least somewhat involved in the discussion and says, wait a minute, you know, this is really a stupid location. We should treat that up front because we cannot jeopardize this, or this needs to come out now, because if it grows by 1 more millimeter, we're in deep trouble. And so I think for patients, and I don't want to say insist, but really work with their oncologist to kind of get this, what I would call multidisciplinary care, I think is actually in everybody's best interest, the patient's best interest, but really also the team, because again, I consider cancer care really a team sport. I mean, we have the main, you know, our athlete, our marathon runner, which is our patient, and we're the coaches. We're really the people to make sure, or should make sure, that our patient is well at every stage of their journey or their run. I always kind of refer to it as a marathon, because we will hit, you know, the going up the mountain, or, you know, running downhill, or the cruising part. But the more eyes on a patient, the better. I know, I'm sorry. I love to talk, so I'm sorry.
No, I love that.
Sorry,
listen,
Melissa.
You're talking to a full-blooded Italian over here. I am a talker too. I get it. So I do have a question, so that I think will help our patients too. Like, the vast majority of folks that have brain metastases are not going to conventional surgery really anymore. It doesn't seem like, unless, like you mentioned, it's in a terrible space, or it's a large tumor that they think is going to cause a problem. So that lends, you know, us towards the radiation field. So we have, you know, stereotactic radiosurgery, which is such a specific thing, and whole brain radiation, which is what was used in the past. Can you speak to the differences between those two, and what the, you know, makes the choice between the two? Or
yeah, so and you know, I'm kind of cloning now my amazing radiation oncologist next to me, and I'm not going to claim to explain it perfect, but so the broad differences with stereotactic radiosurgery, or SRS, that you sometimes might hear or read about, or sometimes referred to as gamma knife. And I'm just going to mention these different words, because when people go online, they see different things and it's confusing. So stereotactic radiosurgery, it's really not surgery with a regular scalpel, but it's literally kind of trying to more or less three-dimensionally like burn out that lesion in the brain. So the way to think of it, again, if you think of your brain as this ball or this big walnut, and you do have a lesion right in the middle of it, with radiation, as the gamma knife or the SRS, you can actually really target all those little different beams that are coming from very different direction, or kind of, if you think of a bicycle with all the little, I don't know how you call them in English, I'm being German. So yeah, so with those, they all kind of meet in the middle. And so the radiation doctors can actually position your brain and the machine around it, that all these things meet in one spot. And that allows us to concentrate all that radiation energy in one spot and kind of burn the tumor from the inside. I guess that's the best way. And what they do also, you can do this in a somewhat three-dimensional way, so they can shape it, even if it's not a perfectly round metastasis. And what they then add is they add like another kind of safety rim of a little bit lesser radiation, to put it very simply, around that kind of inner core that catches, you know, the whole metastases, to kind of create a safety zone. And this SRS, you can do again for a good number of brain metastases. Now, different centers will have different cutoffs in regards to how many SRS lesions do they do in one session. It used to be only 3 to 5. It has gotten higher. And this was just, again, as technique has evolved over time. There are other things to consider with SRS, is the size of the lesion. So if it's too big, even if asymptomatic, we really can't do that. And again, it depends on the patient, it depends on the location and the overall performance status. But one of the magic cutoffs is roughly 3 centimeters, which is a little bit over an inch, where we say we can't do SRS anymore. So an SRS typically is a one-time, one-day outpatient procedure, and it's kind of like one big beam or one shot. The whole brain radiation is a little bit different in that we radiate literally like the whole brain. So really kind of we're mapping out the brain from, you know, right above the eyes to kind of the back. And we give radiation. And again, the standard is, even though, you know, there are some varying small minor differences that probably have no bearing on how patients do with it, but you radiate the brain up to 10 fractions typically, and you give a total of 30 gray, but it's a lower dose of radiation to the whole brain over multiple days. And that has obviously a different, I guess, side effect profile. You would lose all your hair, for example. It will grow back, but sometimes in a little bit of a funky pattern, I would say. And it's typically not something that we can do again. So once you have received whole brain radiation, in extremely rare and specialized cases, we do a second round. But again, I would say we really never do it, and has also different potential side effects. Again, when do we use whole brain? We use whole brain, again, based on the number of the lesions, if there are too many. Because if you think again about it, when we use this really high effective beam that literally kind of, again, lasers, beams, you know, fries that tumor that we can see, it really doesn't affect tumors that we might not see, that are literally just a quarter or half an inch away, and they just haven't shown up on the MRI, but there are cells hiding and looming. Now, whole brain, the hope is that it could also catch these that we can't see, but we don't use that whole brain radiation as a preventive tool, if that makes sense. So we only use this for treatment in somebody who has a good number of brain mets, because we kind of know that we couldn't just kind of radiate all those little 20, 30 lesions, because it just wouldn't work, because sure enough, you would just have too many pop up. I hope I explained that right.
No, that's perfect. And I have actually seen it used where, like in this patient population where there are 20, 30 lesions, where there's whole brain radiation that's sort of done, and then SRS can be done on areas that, you know, continue to grow or that become problematic after the fact. We've seen that at least at our institution and in our radiation oncology department as well. So like everybody has their own little like approach, I feel like, which is why it's
absolutely. And yeah, go ahead.
No, you're good. I was done. You're good.
So yeah, and I think to kind of maybe stay with kind of the radiation part. So as I mentioned, you really can't do whole brain over and over, and you really can't radiate gamma knife the same spot over and over. But what we see actually quite often is, let's say we start with gamma knife or SRS and we treat 5 lesions and the patient is doing wonderful, but a few years later they develop 50 new brain mets, and we don't really have any other good options from the drug department that I could give. We will recommend whole brain. So we can actually do whole brain. And let's say the patient is doing okay with the whole brain radiation. If 6 months later, another 3, 4 new lesions pop up, but they're, you know, very few, we could do SRS again. So we can kind of sequence these things, but we could not do whole brain and whole brain and whole brain. And the other way around goes also, if we have to start with whole brain, we can do SRS in the future if needed to selective lesion. Again, it will depend on the total number of lesions, the size of the lesions and things like that.
Well, this is a good transition too, because now we have drugs that we know can help from a systemic approach with the radiation. I know one of my favorite oncologists in the whole wide world, Dr. Tavi, at your institution actually published a great study with, you know, how immunotherapy crosses the blood-brain barrier to kind of help with that. So, you know, from a systemic therapy standpoint, you know, can patients with brain metastases get treatment? Because there used to be a very big, you know, stigma against, especially clinical trial involvement with patients with brain mets. That doesn't seem to be the case anymore. You know, we have like buckets. We have targeted therapy, as you said. We have immunotherapy. So, you know, how do you pick in that regard? You know?
So I think you mentioned a few points, and sometimes patients always ask me, well, what can we do kind of to help the field? And, you know, I'm not asking everybody on here to march to Washington now and lobby, but I think definitely what has happened over many, many years, that, as you mentioned, brain metastases patients were excluded from many, many clinical trials. So what happened is that we had all these great drugs that were FDA approved or that were having great results for extracranial disease, but they all excluded initially patients with brain metastases, and then kind of either in parallel with very, very small numbers, you know, 35 here or 60 there or 20 there, nothing compared to the 900 patients plus that were enrolled in, you know, some of the Checkmate or Keynote trials that were looking into immunotherapy allowed patients with brain mets. So I think we as a field or as the physicians and advocates for our patients really have made some headwind in insisting that patients are being even enrolled in early clinical trials that might not yet have the great efficacy data available, might not even have FDA approval to provide more option to those patients. But to come back to your question of how do I choose, again, what to do for what, and maybe even skip radiation or surgery altogether, because the clinical trial that you mentioned by my colleague, Dr. Tabi, who I know we snatched from Pittsburgh to bring down here to warmer areas, published. So this was a trial that, again, for the most part, had patients that weren't treated with either radiation or targeted therapy, either if they had a BRAF mutation or not. And they were started on this combination of ipilimumab and nivolumab, so the two immunotherapies combined. And what we saw is that a good number of these patients, over 50% actually, had what we call a response. And maybe for the audience to also understand, when oncologists talk about a response, it's not that it just shrunk by 5%. It typically has to hit a bar that is over 30%. And so, or shrinkage actually, so the other way around. So a decrease in the size of the lesion. So over 50% of patients actually had shrinkage in the brain without any other treatment, without gamma knife, without surgery, without nothing. And so I think this was just incredibly encouraging, especially because the side effects that we see with ipi-nivo that are not negligible, but were not worse in patients with brain metastases. So we really didn't see a huge amount of or worrisome new side effects that were particular to the brain, meaning not everybody suddenly developed more brain swelling or seizures or any other, very, very bad side effects. So patients did actually really well. And so that definitely has been something that I feel has changed the field or the approach in general, where we don't immediately go to radiation. And I know I keep on saying gamma knife. I don't mean to, I really mean to say SRS because they're a slight difference. And so, but again, this is where it's nice to actually involve your radiation oncologist and say, hey, I have this patient with 6 brain metastases. They're all not huge. I really would like to go in with upfront immunotherapy. Do you think that's reasonable? And it took a little bit for our radiation oncologists to be okay with this and see more and more patients where it worked beautifully before they also felt comfortable. But I think the key then again is when we do this, we need to monitor the patient. And again, that means we need to do early MRIs to really check on and see if they're having a response. Now, the kicker, as excited I can get about the data, because it's really been, I have seen patients that had numerous brain mets, and of course it was this gut punch. It was this, they Googled and they looked online and they saw, oh my goodness, the old historic overall survival, was usually quoted 4 to 6 months. But, they're young, they're children, and, they're alive and well 5, 6, 7 years later, and they've never had brain mets come back or their disease, they're cured, right? And so, but the caveat is, or the big takeaway is that this really just works very well in patients who don't need steroids.
Right.
And so again, when I look at this patient's MRI and the patient obviously, but often I have the MRI available before I see the patient, this all runs through my head. Again, lesion size, location, but does this patient need steroids? And that would be again defined by the grade of potentially edema that we see on the MRI, but also by symptoms. And so this initial great trial, very luckily, and I think it was a great thing that they did this, had then a second arm, kind of a mini sub-study using the same medication, the ipi and the nivo, ipilimumab, nivolumab, we just shortened it to ipi and nivo, and allowed patients with steroids onto this trial. And it really was a very small number of patients. They only had a total of 18 patients that they actually enrolled in this subgroup. The initial trial included 101, so really only a fraction, but it was very, very clear that patients with steroids, and the steroid dose was only 4 milligrams of dexamethasone, so not even very high by our standards, it just didn't work as well. It was, we're talking more about maybe, in the low 20s, so a significant difference in efficacy. So that's kind of the immunotherapy part. What we also know from some studies that it really seems that the combination is better than just using, either the pembrolizumab or the nivolumab. The numbers are definitely less favorable. Does it still work in some patients? Absolutely. And again, I think this is where you do need to have the discussion about how frail is the patient, what's their performance status. We have to take this into account whenever we treat anybody. But we do prefer the combination, especially if we decide to go in without radiation and try what you really called it the systemic approach, where we try to treat from head to toe.
And back to where your brain is spinning and all of that. If a patient is on steroids, that's where the BRAF status becomes extremely important too, because that also has shown benefit in folks with brain metastases. So
exactly,
you don't want to let that go either.
Yes, so absolutely, and we should not, as much as I think there continues to be this general excitement about immunotherapy, and rightfully so, we should not forget the usefulness of targeted therapy or BRAF MEK inhibitors in the setting, absolutely. And currently, the only large clinical trial that is randomized and prospective, which means, again, for the listeners, that means that we decide to make a clinical trial, we have a protocol, and then we enroll the patients, and then we look at all the data instead of going back to our charts and say, which patient did we treat with XYZ? So that is retrospective, and prospective trials are really the ones that are always better and more powerful, because the patients have to fit all the eligibility criteria. They have to somewhat be in similar buckets, so we actually can make comparisons. So there was actually dabrafenib, trametinib, or this combination is currently the only one that has large prospective data for the efficacy. And numerically, the response rate might be even a little bit higher than what we see with immunotherapy, but what we call the progression-free survival seems to be less. And to maybe oversimplify it, they don't last as long even if they work. And again, that is not true for every patient. I want to be very clear. There are some patients who have been cruising on this regimen for years and are amazing and just great and living life and living life. But there is a little bit of a worry that even if we see an initial response, the disease might grow back. But the question would then be, is that then a time when we could switch them over to immunotherapy or not? So this is, again, when your oncologist would sit down with you and say, every time we come to kind of a intersection and say, okay, now we have either toxicity or we have no more response, the tumor's growing back, right? We need to sit down and look again at all the options that we have for brain metastases. And this is, again, surgery, radiation, systemic therapy, and with systemic therapy, also clinical trials, because the good news is that these days companies, and again, I think it's really patients, they're advocates, but also us who, again, the team that takes care of the patient really has pushed over the last few years to get companies to actually have more brain metastases trial. And I think that's how it should be, that you have also other options that you can try for your patient.
Sure. And I mean, again, I know on many of the clinical trials, it's really, they're looking for stability. They're not looking for, do you have a history of brain mets? That's okay in a lot of cases now. It's more, are they stable? Are you continuing to get new ones all the time? Or are you relatively, you're not on steroids, you had them in the past, they're treated, it's done. And so, I can help with that. That's like from an AIM perspective, I have access to, many, many resources to help patients find these clinical trials that you're talking about. So I always like to put that in, like, if you need help finding a clinical trial that allows brain mets, contact us. We can help you find them. If you're at a small community center that doesn't have, because MD Anderson, the University of Pittsburgh, Sloan Kettering, all these places are big and they have more access to clinical trials, where small, tiny community settings in Wisconsin, in Nebraska may not have that. So, there are resources to get folks those clinical trials. And I just, we could spend another whole day talking about that. So, but I do want to touch on a very specific subset of brain metastases, because it's one that has been historically very hard to treat, that up until really, I mean, truly, I didn't know that there was a person actually investigating leptomeningeal disease, which is this, which you can explain, but very crudely spread of the melanoma into like the lining of the brain and the spinal cord and et cetera, et cetera. But I didn't know that there was someone like you out there that was actually looking at this small subset of patients. And actually one of our patients several years ago said, oh, I'm going to go see Dr. Glitza because she's running clinical trials on leptomeningeal disease. And I thought, well, by darn, look at that. And really, you're doing a great service to so many patients who, you know, by and large, this is a really difficult prognosis and a difficult diagnosis in general. So if you would please, you know, speak to leptomeningeal disease, because I know there's listeners out there that really need to hear this.
And thank you for your kind words. If you would see, I actually just get goosebumps because, you know, every time leptomeningeal disease is mentioned, this is really where, so, I mean, yes, I am a melanoma medical oncologist, but my passion is, and sorry for the listeners that might come and see me and don't have brain mets, but my passion is brain metastases and advancing, you know, and advancing the research and the care for these patients. And within even the whole brain mets bucket, really my passion has been for 8 years now, the treatment of patients with leptomeningeal disease. And I should give my mentor, Dr. Nicholas Papadopoulos, who retired in his, he never told me, but I think it was his late 70s, and who I learned, you know, everything that I know from and took over the program from him and expanded it. And maybe I should throw out some, you know, just bad numbers, but then kind of saying that, again, hearing the number is one thing, but seeking help and you know, not giving up is another thing, right? I think those are two things. And we humans need hope, and we need also to know that we tried. I think that's very, very important. So leptomeningeal disease, when I come back to my, how do you call it, walnut model. So I actually explain that to patients in my clinic. So think of your brain as a walnut. We took the shell off, or pecan nut. I don't really care. In Texas, it's more pecans. But so you look at this nut, and it has this brown little thing, thin skin on it, right? So all nuts have skin. And these are actually your meninges. And so that kind of already shows you that that's the issue, because the whole nut is covered with this little brown skin and the meninges. So, and if you think again about the nut shell, I guess, as your skull, the layer in between, very simplified, but between the skin of the nut and the shell of the nut, that's where the spinal fluid is, the cerebrospinal fluid, and it's all attached not only in your head, but it goes all the way down to your spinal, to your sacral bone. And so this is all one canal. Or if you think of, you know, the balloon people who make you the flower, it's all one connection. You know, you have one connection, and the melanoma cells can just travel up and down. And so that's why, for example, things like SRS are not really an option for leptomeningeal disease, because if you just kind of zap one area, there's for sure more coming up. The way I describe leptomeningeal disease is, again, if you think again of your nut model and the skin on the nut, we put a little bit of powdered sugar on it, and the sugar will fall in different amounts into grooves, and it might not be visible in one, but it's, you know, more concentrated in others. But if you would shake it, it would be kind of all over the place. And so this is sometimes or often, unfortunately, a scenario where, again, we cannot do the SRS, but we can do whole brain radiation. It's truly palliative. We have not really seen that it prolongs life, but as most patients with leptomeningeal disease have a lot of neurological issues, it can at least help with these. And sometimes that's really an important thing, what we call to prevent, you know, significant neurological decline right there. But to kind of come back to your trials, or to the thoughts of what can we do. So again, the life expectancy is still awful, and it's heartbreaking. I mean, we just recently looked at 178 patients with LMD at MD Anderson, and it was the median overall survival was just 3.5 months. So something that we just, as a field, cannot accept and just shrug our shoulders. So we started a program of using intrathecal immunotherapy as one of the potential options for these patients. But I really have to also give credit to many, many centers throughout the United States that really have recognized that this is an ongoing area of really unmet need. And again, it's not just I would sit here and say brain metastases are still not solved. I mean, we still, you know, have many, many more battles to win and provide so much more hope and options for our patients. LMD is kind of the step trials. And so I think the good news is, again, is that companies are having more interest. And when I say this, it's really, we need to work together to help our patients. I can't do it myself. The companies can't do it themselves. So we need to bring all of us together and, again, make sure that patients have access to more drugs for this, you know, very, very, very difficult, complication of melanoma. But it's not in melanoma. So leptomeningeal disease is kind of just, again, a complication of metastases to the brain. And again, it can happen from any tumor type, not just melanoma. But yes, it's an area of unmet need and just devastating diagnosis. It is.
So with and this is more of a personal question, to be honest, is it that we don't know how the drugs penetrate into the like cerebral spinal fluid and how, you know, like how to keep them in there so that they can treat, or we just don't understand a lot about leptomeningeal disease in general, I guess?
So I guess my first disclaimer would be we don't know a lot about leptomeningeal disease in general. We don't still understand, and the same even goes for brain mets to a degree. We don't understand why some patients are filled with cancer below the neck. And again, I'm just going to say this, you know, have tumors everywhere and nothing goes into the brain. And then we have patients that were stage 1, again, which is a very low likelihood of ever progressing into the brain. And they have suddenly 10 brain mets 10 years later. And you saw, how did this happen? And we have some patients that have only leptomeningeal disease. So it's only on the lining or inside of the ventricles. They don't have the chunky, or not even chunky, but the mets that are kind of inside of the meat of the brain. So we don't really understand yet why in some patients the brain becomes kind of the preferred niche, the preferred, you know, homing area, the preferred, you know, neighborhood to be. But we do know a little bit more about drugs these days. So we do know, for example, that the targeted therapies, and again, there's only currently published data out for dabrafenib and for vemurafenib. We do know that these agents can cross the blood-brain barrier and penetrate into the CSF or into brain parenchyma. But we do know that the levels are different. So what we measure in the blood is higher than what we measure in the CSF. So again, the thoughts are, you know, at one point, what are strategies to overcome this? For immunotherapy, and I'm glancing with one eye into the chat box too. For example, immunotherapies, do they cross the blood-brain barrier? And so antibodies don't as freely cross into the spinal fluid or into the brain in a healthy brain. But there is some data that antibodies actually can get, again, into the CSF or into the brain. But you have to remember that the immunotherapies are also a little bit different than the targeted therapies that really work by affecting the cells directly. The immunotherapies are using your immune system as an intermediary, right? So they alter, you know, either the interaction of the T cells with, for example, the dendritic cells, or then with the tumor cells. So we do know that they can actually get into the CSF or into the brain. But again, it looks like at potentially lower levels. But again, with a big caveat that we don't have large numbers on there. It's very, very limited data. But there seems some evidence that small levels get in. And again, somehow it's either the T cells that are getting into the brain or, right? And so maybe I should say one more thing. So in brain metastases, again, with LMD, we don't know this, but in brain metastases, we know that the blood-brain barrier is altered, right? Because tumors are sometimes causing their own new vessels, they're interrupting some of the existing blood vessels. So there might be at least some level of disruption of kind of a healthy blood-brain barrier that might help getting some of these agents in. And to kind of answer another question from Frank that I saw, to kind of using radiation and immunotherapy, for example, together. There is no great prospective data yet available, again, meaning
Correct.
large trials at the efficacy of using these together. But I can tell you in clinical practice, it's being used often together now.
Mm-hmm.
And it seems to be very safe for the most part. And what we also have now is much data looking back again, the retrospective data that is not as clean, but at least gives us some guidance that it seems to work. And that again, in some patients, it seems to actually work better when you use both modalities together. And one other thing I maybe should say is that a lot of the trials now that are looking for patients with brain metastases often actually allow to use SRS while the patient are on trial. If one or two lesions are acting up and the other ones, for example, are shrinking, that we can add this on with a thought again that maybe we just need to hit these extra hard, but then kind of the response continues or actually even deepens. So to a degree, 2012 might have been a very cutting edge approach to therapy, if that makes sense, and to combining two different treatment modalities in one patient in a very similar time frame.
Well, and also there was another question in the chat saying, what if you're on both immunotherapy and targeted therapy? And I know that you know, there are patients without brain metastases that are on triplet therapy like this. There was recently a triplet therapy that was approved by the FDA. And so, you know, there's no limit to the number of things I feel like that we can do in terms of treatment, which is extremely helpful. And, you know, I know that not only are there clinical trials going on, but, you know, the oncologists are using this as part of, you know, a multidisciplinary approach to patients.
And
one of the things,
there has been some data, there has been some data. It's again, it really wasn't specific for brain metastases, but it allowed patients with brain metastases where the triplet has been used. And again, you know, it works in some patients. And to your point, Melissa, to a degree, yes, it seems like the options are getting more and more. And you sometimes just say, well, what's next? But I kind of really would like to point out that the nice thing is that we are having at least more options now. Again, like 3-5 years ago, I feel it was a complete deserted, I don't want to say shrugging your shoulders, but you know, it is wonderful that we actually now can talk in our clinics to patients and say, well, if this doesn't work, we can try this. And again, there are other trials, like you mentioned, that are now using other triplets or combination therapies that include, for example, one or two elements that are not yet FDA approved for melanoma specifically, but might have had some benefit in other cancers, where the thought is, from a scientific standpoint, if we throw these together, maybe they don't only work in the brain, but they kind of work from very different approaches. And I call this, you know, the multi-prong approach. And again, one of the modalities is actually, or one of the approaches is, for example, using radiation with immunotherapy together. And maybe if I can steal 3-5 more minutes, the only other thing that we've also seen that might have been a slight increase since using immunotherapy and SRS together is something called radiation necrosis. And radiation, I'm sure you've seen a good number of patients that are coming in with what we think is radiation necrosis. And really what it is, as it says, it's driven by radiation, and the amount of radiation, the size of the lesion, the volume, all these play into an increasing risk of radiation necrosis. And there are multiple hypotheses why we think this happens, but one of the drivers seem to be hypoxia, and then a change in vasculature that makes the tumor, and actually the cells around the tumor that was radiated, release something called HIF-1 alpha, hypoxic factor. And that then in kind of as a snowball system then leads to higher VEGF productions, and that's like a vascular endothelial growth factor. I'm sorry, I'm getting a little bit technical, but that is really kind of driving kind of this inflammation in the brain and bringing in new vessels, and they're very frail and they can have a lot of edema. And sometimes patients are sicker from the radiation necrosis than they were from their initial brain metastases. And so while I think we take this into account that radiation necrosis can happen, you know, we should educate our patients again that if we use, for example, combined therapies, using, again, for example, radiation plus immunotherapy, that we might increase this risk. But
okay, and it's treatable though, correct, to some extent?
So it is treatable as a general, generalized statement, yes, but it can be sometimes very tricky. So again, sometimes the radiation necrosis is harder to treat and can be more pesty and can cause the patients more symptoms due to the swelling than the original brain metastases. But kind of just a quick check, steroids, again, dexamethasone is one of the therapies that we give and to see if the edema is going down. Then we've used things like bevacizumab. We've also used things like LIT, which is laser interstitial thermal ablation. LIT, yes. So it's kind of, the neurosurgeons would be better in explaining it, but you go in with like a little probe, so it's a neurosurgical approach, or you can cut it out, the whole thing, but sometimes you can use LIT. And what they do, they literally kind of burn the tumor, or not the tumor, actually, the necrosis from the inside out and prevent kind of this inflammatory propagation. So again, the field has come a really, really long way over the last few years, but it is treatable, yes, for the most part.
So I'm going to go back 1 second. I'm going to explain radiation necrosis from the way that I try to explain it to patients. So when we treat your tumor and cause it to die, so when the tumor cells, you know, decide they're going to be not active anymore, they get starved of blood. And so one of two things happen: either they shrink and die and go away and your body gets rid of it, or sometimes, and this is where radiation necrosis happens, you get this death that causes inflammation. So it's sort of like that bruise that won't go away. It's like your brain is hurt. And when your immune system recognizes that your brain's hurt, it causes swelling, and that is, it's primarily really the swelling and inflammation that causes the problem, not the actual tumor. Right? Is that correct?
Because the tumor is because the tumor in theory, and so whenever we really talk about true radiation necrosis, that actually means the tumor has been gone. So in theory, the tumor is dead, and then all what we are left with is kind of the aftermath. And again, sometimes that's and you're right. I mean, it's really it's in some patients the swelling is tremendous, and again, causes them to have issues, but the tumor is gone, if that makes sense. But again, in some patients, we have both. We have radiation necrosis in one part of the brain, and then in another part of the brain, we actually have tumors, and that makes it not easier, obviously.
Yeah. So,
but again, that's when you get your whole team involved.
Everybody has to be involved and help us. Let me just really quickly browse through the question and answer thing just to make sure that there's not anything. Kathleen, whenever we're saying cyberknife, like with SRS, cyberknife and gamma knife, there's actually a couple different kinds of SRS. So it's not exclusive to gamma knife. Cyberknife is also another example, you know, that is sometimes used. It's actually very, it seems like very institution specific, in terms of, you know, if they have somebody that uses that particular type. I know, you know, there's one hospital in our academic system that uses gamma knife and the other hospital uses cyber. So I think, you know, there's a lot of variability there. And I think you got all the other rest of the things. It says, why, Margie asks,
Melanie, okay,
Margie asked a question: what does metastatic melanoma in other parts of the body, why does it seem to like the brain as a site to go to?
So we don't know yet for sure. Yeah.
Right.
So we don't know for sure yet. So it's kind of the same weird question, not weird question, not, sorry, Margie, not your weird, but kind of the same question. Why does uveal melanoma just love to go to the liver in like over 90% and nowhere else? So there seems to be, again, some melanomas that there are some shared, I guess, environment in the brain and where it came from. But we do know that brain metastases have sometimes a slightly different composition in regards to the immune cells that we find in there, and actually even sometimes different type of mutation, not necessarily, you know, that they don't turn from a BRAF into an NRAS or vice versa, but that they might have other mutations that happen within their environment that makes them, for example, either more resistant. So I'm sorry that we don't have a good answer yet, because obviously the goal and the dream would be to prevent any melanoma to travel from the skin to any other organ, but again, specifically in the brain. And I know that Melanie also asked quickly the stats for mets progressing following adjuvant therapy. So we don't really have great data for that yet. I can tell you that there was a recent publication that looked at, now I'm probably quoting wrong, but nearly 2,000 patients, I think something around 1,900 patients that had anywhere between, you know, stage 3A through 3D melanoma, stage 3 melanoma. And we looked at the risk of brain metastases developing in each cohort. So if you want to look up that paper, that is not though following adjuvant immunotherapy. So it's a little bit different. And one of the problems is with all the current other things like, how do I phrase this best? So for example, when we talk about the Ajcca staging system, which is the newest staging system that came into effect about 3 years ago, I think 2018 it was published. So we obviously have the bucket stage 3A through stage 3D, and we have all those nice curves in regards to survival and, you know, risk of recurrence. But the problem is that this is a huge bucket of patients where some of them actually, but only the minority has received all the new adjuvant therapies that we have available, either immunotherapy or targeted therapy. But really the majority of these patients, because most of them had, you know, we tried to have a 10-year follow-up, those drugs were not available when those patients were treated. And so some of the data, I think, over the next 5 years in regards to risk of progression as a huge pool for patients, we will have better data. And the same will go for risk of progression following adjuvant therapies. I know, or I believe, that at ASCO there might be a poster or so looking into this, or at least describing institution-specific data, but we're lacking the larger publication, if that makes sense. But it's a great question, and I think we got it.
That's what I think. You got everyone else. I just want to kind of group one more thing. I know we're like super running so over, but this is such a great topic that I just want to pick all the information out of your brain. So you had talked about surveying patients that hadn't yet had brain mets. Just very quickly, patients, once they've had a diagnosis of a brain metastasis, surveillance is obviously closer. I don't want to put words in your mouth, so I'll let you say what, you know, you think it should be. But, you know, again, there aren't guidelines out there. So
you mean once they were diagnosed with brain mets, right?
Correct.
Yeah.
Right.
So if they are on treatment, it's been done a little bit different. So depending on what you treat with, I've seen, and again, now I'm speaking more broadly about the community in general. I think I've seen if somebody's diagnosed with brain mets and we decide to go in with either targeted therapy or immunotherapy, I've seen scans being done as early as 6 weeks or 8 weeks, just because you do want to check is that, you know, are we heading the right way, or are we running into problems and we just haven't, you know, the patient hasn't had symptoms yet, so we see this. So I would say, you know, probably I would do my first scan somewhere around 8 weeks just to kind of get an idea, or even before. And then if everything looks great, I would feel more comfortable going again to kind of a roughly every 10 to 12 week schedule, which would kind of match what I would do for my extracranial scans, right? So on treatment, if everything's going well, I typically go roughly every, 10 to 12 weeks and do both in the brain and the body, and eventually we'll spread out. So I think, I'm not sure, Melissa, how you typically recommend what we do, the first year every, 3-4 months, the second year similar, and then year 3 to 5, we spread out to every 6 months. And again, these are just kind of rough numbers. They obviously, if there's any other new symptoms, we absolutely need to go in and check earlier, or if the patient is fine, we'll just kind of continue and cruise. And again, sadly to say, but sometimes, can't get insurance to pay for it, which.
I know, we don't even have to say words about that. It's very frustrating as a treating provider about that.
Yes, I could not agree more.
Well, I am so thrilled that you came on here with us and provided so much knowledge to all of our patients. This is going to be available, for folks to watch after the fact on Facebook and on our YouTube channel. And I, can get any complicated it's can be available forever. If there's ever anything that comes up, that I can't handle, I will certainly forward those questions that may come up after the fact onto you. But I truly in my heart appreciate so much that you came, to talk with us tonight. So.
Thank you. And I also would like to, wish all the listeners all the best, and, just stay strong. And it's a marathon, as I say, and I'm wishing you all the best. And again, thank you so much for having me.
It's wonderful. Have a wonderful evening, everybody, and we will see you next time. Bye now.
Thank you. Bye-bye.